Welcome. This is Dennis Scanlon from the Center for Healthcare Policy Research at Penn State University. And today we're going to do another segment of Ask the Experts. Today I'm speaking with Dr. Mark Fendrick, professor of the Division of General Medicine and in the Department of Internal Medicine and Department of Health Management and Policy at the University of Michigan, and importantly, director of the University of Michigan Center for Value-Based Insurance Design. Mark happens to be someone I've known for many, many years, a friend, and he's done great work on this topic of VBID, which we're going to get into. And importantly, for those of us here in Pennsylvania, Mark is a Scranton, Pennsylvania native. I think his mother insists that he will get back to Pennsylvania at some point. We'd love to have him back, but he's been in Ann Arbor, Michigan for a number of years. Mark, welcome, and thanks for taking a few minutes today to talk with me.
Dennis, it's great to talk with you.
So, Mark, I want to start off with talking about insurance generally, because I think one of the things that your work has really pointed out is that all insurance is not equal, despite the fact that I think when it comes to reform and policy, there's so much focus with the ACA and certainly what's going to come in this next administration. A lot of the talk is going to be on insurance, giving people insurance, how people access insurance. But the work that you've done over the years really suggests that one insurance policy is not equivalent to another. And it's this concept of value-based insurance design and really looking under the hood at what the terms of the insurance policy is, what it does or does not cover, how much it covers. Can you tell our audience here a little bit about that concept of value-based insurance design, or VBID, which we'll refer to throughout the course of this segment?
Well, first off, Dennis, I think it's important for the audience to know that I am a practicing primary care physician. I do not have any of the background in social sciences like you and many of your colleagues there in State College. So I came into this a different way. I think you asked a lot of things in that first question. First, it's about insurance in general. It's very interesting to talk to people who are somewhat confused about health insurance because it's really different, as you know, from auto insurance and homeowners insurance and the type of insurance that a typical American will buy, which they will hope never to use. You hope not to get into a car accident. You hope not to have your pipes burst or your home robbed. And that's why, first off, semantically, it's somewhat complicated. That what we're really talking about is an efficient delivery of healthcare services, because since most of us do agree that health insurance, so to speak, goes beyond that covered of a catastrophic event like auto insurance and home insurance, but we'll cover at least some of those services that will keep you healthy. So there are very, very rare auto insurance policies that actually cover your oil changes and your tire replacements. And I think that is a very, very big difference as you start getting into the issues of premiums and deductibles. So first part, health insurance is not just, at least in my mind, covering for that catastrophic event if you have a bad accident, unfortunately, or diagnosed with a critical condition. But my view is health insurance, as we call it, I think should allow access to individuals, the services that will keep them healthy. So thus the transition from a standard insurance program to what we call value-based insurance design. As you know, and what is certainly a very big deal in the Commonwealth of Pennsylvania, is people are being asked to pay a lot more for their health care, whether it be for their premiums, for their health insurance policies, which they pay up front, or at the point of service when they see their doctors or fill their prescriptions, as they're asked to pay co-payments, which are fixed amounts, increasingly co-insurance, which are percentages of the bill, and deductibles, which you actually have to pay up front the full amount until your plan deductible is met, which you know, Dennis, is a major issue of mine. So, do you want me, so that was you asked a lot. So I'll go to the second. So ready. So most insurance policies, including many of the insurance policies that I've studied in the Commonwealth of Pennsylvania, when you look at what individuals have to pay at the point of service, I like to decide that they're one size fits all. You pay the same for every doctor visit, whether it be a cardiologist after a heart attack or a neurologist for mild acne. You pay the same for every diagnostic test, same for the drug within the formulary, such that you pay the same out of pocket for a generic drug to treat life-saving illnesses like diabetes, depression, and HIV, as you do for generic drugs to make your toenail fungus go away or your hair grow. So thus, I love to say, in the last century, one of our mutual colleagues, Michael Churdu and I, basically decided that wouldn't it be better if these health insurance policies actually made it easier for people to access things that make them healthier and perhaps make them pay a little bit more for services for which there's no evidence of health. So thus the idea of value-based insurance design emerged based on the concept of what we call clinical nuance. Two key points of that. One is medical services differ in the benefits that they achieve. So thus, I would not argue to have equal incentives for people for all these visits, diagnostic tests, or drugs. But maybe more importantly, and a great challenge to the academic community and the policy community, is understanding that even if a service were high or low value, that value depends not only on the service, but who gets it, who provides it, and where. And I think a good example of this, Dennis, is things like colorectal cancer screening, which you know something I've been interested in for longer than value-based insurance. So thus you have colorectal cancer screening, which you may think is a good thing. In a first-degree relative of a colon cancer sufferer, it's extraordinarily high value. In 50-year-old folks like us, it's high value. But in a 30-year-old who was moved by Katie Couric's Today Show colonoscopy with no family history, it's an exact waste of money and may actually be harmful. Same holds true for the high-performing provider and the low-performing provider. You want to steer your patients who do well and efficiently and safely. And lastly, what about the venue? How about an ambulatory care center where you have the high-qualified gastroenterologist or surgeon doing that same colonoscopy where he or she can do it at 1/3 the price as, say, a hospital ambulatory endoscopy suite? So the idea of clinical nuance is particularly interesting, and I would like to leave this concept with your viewers as that my 3 favorite high-value services are colonoscopy, coronary stents, and back surgery. My 3 favorite low-value services are colonoscopy, coronary stents, and back surgery. And I hope as they think through that idea of clinical nuance, they'll understand what I mean.